channel. Today we're going to talk about the chest pain. I'm not going to waste your time. We'll just move on to the topic. So this is specifically for the KU MBBS final year exam because we see the chest pain in every question. So bear with me. We'll go through one by one. So when you're talking about the chest pain, the core rule that is to first rule out the life-threatening causes. That can be like ACS, MI, acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, cardiac tamponade, and even the esophageal rupture. The important life-threatening causes of chest pain that you need to differentiate when the patient presents to the emergency. So everything is should be approached towards ruling out the life-threatening causes and then go to the common causes and then go for the rare causes. Okay, so how to write the chest pain in KU MBBS? We write it by emergency stabilization. We could do the focus history. Um, we do the ECG, troponin, we enzyme, and then basic labs you need to fill out. Separate killer causes from the stable, non-cardiac causes. You need to separate that. Give cause-specific management, not only a list of causes. Okay. We'll go one by one regarding this. Okay. So first, when the patient comes to the emergency, we'll approach them. We'll go talk to the patient, then give me the answer like that. So first, we'll do the ABCD. Any emergency case, we'll do the ABCD. Then we do check the vitals. We check the SpO2, uh, and then we put on the cardiac monitor. We gain access to the veins, and if needed, if the patient is in cardiac shock or hypovolemic shock, we give the blood, we give the fluids. Then immediately after that, we put on the 12 lead ECG immediately. Once the chest pain is suspected, you need to do ECG. And if further investigation is needed, we need chest X-ray. Uh, and if a certain diagnosis is suspected, just go for that and treat them. Red flag sign that you need to look is basically for the emergency cases, like if the pain is central crossing and radiating to the left arm, jaw, um, relieved by the wrist, or not relieved by the aggravated by the exertion, then you are thinking of the acute coronary syndrome or MI in particular. Um, you need to act fast in MI because you need that reperfusion window. Now, when you're talking about the aortic dissection, there will be tearing pain and then it will radiate to the back. And there will be unequal BP between two upper extremities, left and right. And we need to, as treatment, maybe beta blocker, or depending on the type, if it is a type A, if we give we go for the emergency. But then before that, we need to reduce the BP. When you're reducing the BP, you usually reduce it by 25% in the emergency cases, be it the hypertensive emergency or hypertensive urgency. But in case of aortic dissection, you can reduce the BP fast, very fast. Like it doesn't have to be 25% limit. Okay, so and you don't give anticoagulant in this scenario. And if it is a type A, after giving a beta blocker and controlling the BP, you go for the surgery. Now, talking about the pulmonary embolism, patient might be in a shock, treat accordingly that. There will be pleuritic pain, dyspnea, and DVT risk. So, anticoagulant, you need to act fast. This also. Tension pneumothorax, you need to do decompression with a needle, and then later on, maybe depending upon the size or like the how big is the pneumothorax, you go for tube. Now, talking about tamponade, you need to, there will be Baxter, that will be hypertension, raised JBP, muffled sounds. You need to do pericardiocentesis as soon as possible. Now, esophageal rupture, there will be vomiting, there will be blood in the vomiting. You do the emergency endoscopy. Now, you're talking about the history. Again, we discussed that history clue. Pressure crossing is ACS, daring to back is dissection, pleuritic is P, pneumothorax, and pneumonia. Burning after meals is GERD, leaning forward leaves the pericarditis, reproducible. Tenderness is musculoskeletal. First thing you check is vitals, pulse, PP, both arm dissection flu, JVP, heart, lungs, legs. Okay. Differential diagnosis. Differential diagnosis or etiology, important causes. You need to mention the emergency cause, which can kill the patient. Such as in cardiac, it will be ACS, angina, um, pericarditis, myocarditis, tamponade, aortic dissection, pulmonary embolism, pneumothorax, pneumonia, asthma, and COPD. In case of the GI, it will be GRD, esophageal rupture, PUD, pancreatitis, and biliary disease. Whereas in the MSK, it will be costochondritis, rib injury, zoster, and panic attack. These are all not serious cases. The MSK, okay, investigate. First line will be ECG, you check, and after that, we'll check the enzymes. Okay, troponin and CKMB. You need to memorize the time when the when it rise, when it peak, and normal. I'm not going to go through it. Go through it yourself, and we do the ECG, and there will be sequential changes in the ECG pattern when the patient develop MI. So you need to learn that. Now, acute coronary syndrome, there will be unstable angina and STMI and STMI. In STMI, there will be elevation. Non-STMI, there no persistence with ST elevation. Unstable angina, no ST elevation may have ST depression or TO inversion. But then troponin will be normal and unstable, but then rise in STMI and non-STMI. Now management for them will be same. So ABCD first and all those emergency management, and then you go for aspirin, clopidogrel, and anticoagulation for protocol. Nitrate if we feel allows. Okay, so avoid RV infarcts, hypertension, severe AS, recent PD inhibitor. If it is a right side MI, we give the fluid. We give the fluid because the fluid is not reaching to the left side, so we need to give fluids. If it is a left side MI, then we don't give fluids, but nitrates are avoided generally in the case of RV. Okay, right sided MI. High intensity statin we need to give early, and STMI primary PCI prefer fibrinolysis if PCI unavailable within recommended time. Okay, so now life-threatening non-ACS causes. So it will be pulmonary aortic dissection, pulmonary embolism, tension pneumothorax, tamponade and esophageal rupture, as we discussed earlier. Aortic dissection, we do the CT angiography, and and then we go for the IV beta blocker, and if it is a type B, we go for the surgery. Pulmonary embolism, we go for the anticoagulant. And tension pneumothorax, needle decompression. Then we go for the chest tube. Tamponade, we go for the urgent pericardiocentesis. Esophageal rupture, vomiting, then chest pain, sepsis, emphysema. Okay, so go for NPO, antibiotic, and surgical consult. Now, the main thing you have to differentiate between pericarditis versus MI. If you look at the ECG, you will definitely know the differences. In ACS, it will be ST elevation in coronary artery. And in pericarditis, it will be diffuse concave ST elevation plus PR depression. No reciprocal depression except at AVR of V1. Okay, so pain will be sharp, pleuritic, worse lying down, better sitting forward. And in case of ACS, it will be pressure-like, exertional rest, radiate to arm or jaw. Troponin may be mildly elevated in myopericardis, but then in ACS, it will be raised in MI. Treatment, NSAID and colchicine if uncomplicated in case of the pericarditis, but then in ACS, it will be antiplatelet, anticoagulant, statin, reperfusion, RICS base angiography. Remember, pericarditis is a positional plus pleurity plus diffuse ECG changes, but then in MI it is vascular ischemia, and then there will be specific basal changes. If you're talking about the GRD, we need to manage the lifestyle plus PPI, and if you have a esophageal rupture, endoscopy. Esophageal spasm, you need to rule out the cardiac cause and treat accordingly. Pancreatitis, if it is a pancreatitis, lipase, IV fluid analgesia, treat the cause. Pneumonia or pleurisy, do the chest X-ray, and antibiotics if bacterial. Costochondritis, analgesia, reassurance after reflux is excluded. Okay, so panic attack is a diagnosis of exclusion, fear, palpitation, hyperventilation, and normal workup. Okay, so these are the 10 marks skeleton or like 10 marks questions. So if you mention important and emergency nature of the chest pain, you'll get the marks. Do not write random stuff. Emergency, which can kill the patient, is likely gonna get you a marks. Okay, so history and examination you can mention all those ECG, troponin, chest X-ray, focus, meaning point of care ultrasound, which is EFAS and all this stuff, CT scan when needed, and 2 marks general management plus cause specific therapy, and 1 mark complication prevention follow. Okay, so likely exam question is approach to severe central chest pain, differential diagnosis and initial management of acute chest pain, ACS classification, diagnosis, and treatment. Okay, so clinical feature investigation and management of acute MI might come, pleurisy chest pain with dyspnea, differential and emergency care might come in the exam. So thank you for listening to my video. If you want any topic to be discussed, let me know. I'll be happy to teach you back. That's all for today. Thank you for listening.